Welcome to RAAONLINE. Today's topic is perioperative management of subarachnoid hemorrhage. So, as you all be knowing, the most common cause of subarachnoid hemorrhage is trauma. Usually, traumatic subarachnoid hemorrhage happens in the sulcal spaces as seen in this CT scan, axial plane CT, which is showing some hyperdensities in the sulcal spaces. These are usually the convexity sulcal spaces, that is on the top, and trauma usually causes aSAH in this region. Whereas an aneurysm which is causing 85% of the subarachnoid hemorrhages that happen because of non-traumatic causes. So, the non-traumatic cause for subarachnoid hemorrhage most commonly is aneurysms. So, the aneurysmal subarachnoid hemorrhages usually happen in the basal cisterns. Here you are seeing blood in the thick blood, actually in the suprasellar cistern. We can see it extending in a star shape to both sylvian cisterns, and also it is going along the interpeduncular cistern and the crural cisterns, and also extending behind into the quadrigeminal cistern and ambient cisterns. So, this is how the bleed in aneurysmal subarachnoid hemorrhages. So, you would not investigate for an aneurysm when you see such a scan with aSAH in the convexity sulcal spaces, but even if you see a little bit of blood in the subarachnoid spaces in the base, then you would suspect of an aneurysm. Sometimes the patient might be brought with a history of trauma, a simple fall at home, and there will be blood in the basal cistern. At that point in time, we should not think that the subarachnoid hemorrhage is caused by trauma. It is basically probably because of a small aneurysm which has bled, and probably a sentinel bleed which has not caused much of affection to the patient. So, always suspect an aneurysm when there is a basal bleed. So, as I mentioned, 85% of subarachnoid hemorrhage is in non-traumatic cases is because of aneurysms, but 15% of them can be because of other causes. In 5% of them, we really do not know what the cause of subarachnoid hemorrhage is caused by, but in 10% of cases, it can be because of this pretruncal aSAH. By pretruncal, we mean the prepontine and the perimesencephalic cisterns. So, you can see in this T1 plane sagittal sections, there is some blood in the perimesencephalic cistern here, and then here you can see blood in the prepontine cistern. Sometimes there may be blood in the perimesencephalic and the prepontine cisterns. So, 10% of hemorrhages can be because of pretruncal aSAH, which is usually benign. Benign as in they are not caused by aneurysms, and they may recur, but when you do an angiogram in these patients, there are no aneurysms. So, our general protocol is to do an angio in these patients, prove that there are no aneurysms, and you call them angionegative aSAH. So, when you call them angionegative aSAH, you would like to review them after 6 weeks, ask them to come back after 6 weeks, repeat an angio here again, repeat angio, and then again once the angio is twice negative angio, you call them definitely angionegative aSAH. So, you will need to do angiogram twice in these patients 6 weeks apart and confirm that there is no aneurysm. The cause for these pretruncal aSAH is relatively unknown, but there are some veins which could have bled and caused this subarachnoid hemorrhage. Generally, veins are not present in the subarachnoid space. So, it is some arachnoid rent which had allowed the blood to go inside, but nobody is sure why these pretruncal aSAH happens. So, the causes of aSAH as we have gone through, sometimes it may be idiopathic, as we have mentioned, the perimesencephalic or pretruncal aSAH, and then infections, sometimes TB commonly causes this perimesencephalic, also the basal cisterns bleed. So, they can be causes, infections. Trauma is, as we have seen, is the most common cause of subarachnoid hemorrhage. It can be a closed head injury or a penetrating head injury which causes this subarachnoid hemorrhage. Toxins sometimes can cause subarachnoid hemorrhage, and hemorrhagic causes are usually vascular. These vascular causes can be AVM, aneurysms, most commonly aneurysms, and rarely sometimes neoplasms with a bleed can cause subarachnoid hemorrhage, such as a high grade glioma or sometimes a meningioma and pituitary adenomas, but these are very rare occurrences. So, the incidence of subarachnoid hemorrhage is around 9 per 1 lakh person years. This is obviously western data taken from human. The incidence is fairly uncommon in southern India, but as you go to the higher plains like the Himalayan belt and the northeastern regions in India, you do find that the incidence of these vascular events more. Subarachnoid hemorrhage is much more common in this belt. The colder climates probably with some pathophysiological changes in the vasculature because of the cold climates may be the cause for increased incidence of subarachnoid hemorrhages, intracerebral hematomas in this belt. Sometimes we do see that many of them do not even reach the hospital after a subarachnoid hemorrhage. This 12% is a data taken from western literature. 12% of patients with subarachnoid hemorrhage usually die in the pre-hospital setting or out of hospital. This figure may be to the tune of 25 to 45% in Indian data. So, a lot of them die before even being diagnosed with a subarachnoid hemorrhage. We all do know that some of the best aneurysm work happens in Japan, and no wonder the incidence of subarachnoid hemorrhage is very high in the Far East, Japan and Korean regions. So, let us move on to the risk factors of subarachnoid hemorrhage, and by subarachnoid hemorrhage now we are limiting our talk to aneurysmal subarachnoid hemorrhage, aSAH. So, these are spontaneous subarachnoid hemorrhages which have happened due to non-traumatic causes. The more modifiable factors are smoking, hypertension, alcohol intake and low serum cholesterol. The most modifiable risk factor is probably smoking in preventing recurrent subarachnoid hemorrhage due to an aneurysm or for the development of an aneurysm. Hypertension also is an associated risk factor in many of these patients who have aneurysm, but it is not that any of these risk factors are definitive associations. Non-modifiable risk factors are age. So, increasing age we do tend to see them more in the elderly. Female preponderance is there about 1.6 times that of a male. They generally are more prevalent in female. And ADPCKD, again because of hypertension, ADPKD is commonly associated with aneurysms. Usually these patients tend to have a familial history. They have an autosomal dominant pattern of inheritance. So, naturally the family should be screened for aneurysms. They are probably asked to do an MRI every year in the children once they have been diagnosed with this condition. And familial history of aSAH in 2 first degree relatives also is an indication to screen for this aneurysms. The management of unruptured intracranial aneurysms can be dealt with in another talk, and that is a very interesting talk on the natural history of aneurysms. So, aSAH may be because of a sentinel bleed or a warning leak. This usually happens due to a small tear in the aneurysm, and that does not cause much of symptoms except that the patient has very severe headache, and it usually is left unattended to by the patient sometimes, and sometimes they present to the ED with headache, and a plain CT is done, maybe not much blood is seen in the aSAH and they are deemed okay and probably migraneous headache and sent off, and they then present with 1 week later with severe headache and a large bleed. So, this type of sentinel bleed has been described, and nearly some studies have quoted even 30% history of sentinel bleeds or warning leaks which happen before the actual aneurysmal rupture. This 30% is naturally biased because there is a recall bias in many of these patients. Some of them may say that they did have headache 1 week before, but we can never be sure that they had a sentinel bleed. So, the average bleed per aneurysmal rupture is around 35 ml, which is itself quite a bit of volume to be accommodated in the subarachnoid space. And the higher the bleed volume, the higher the symptomatology. So, more bleed for the patient to the tunes of nearly 100 to 150 ml have been reported. These are all rough estimates based on the scans, and the symptomatology will be more for a patient with a larger bleed, naturally, because the vasospasm also which is more, and also because the derangement of cerebral hemostasis is there, and they do present with more neurological deficits because of the volume of the aSAH is high. So, the pathophysiology, what happens is, once the blood is in the subarachnoid space, it leads to a sudden increase in intracranial pressure, and this sudden increase in pressure causes a thunderclap headache. Usually the basal dura is the one which has maximum pain sensitive structures, and so once there is blood and there is a sudden gush of blood and pressure in the subarachnoid space, they feel what many patients describe as the worst headache of their life. So, this classical presentation is present only in about 30% of patients. In fact, there is a study which has said that out of 100 patients who have aSAH, they found that they have only 5 to 6 patients who presented with this classical headache. In fact, many of the patients who were screened for worst headache did not turn out to have aSAH, but the rough estimate is around 5 to 30% of patients have this classical headache. So, what happens when the ICP raises? The ICP raises to an extent that it beats the diastolic blood pressure. So, once this happens, cerebral blood flow happens only when there is systole. So, nearly we all know that the cardiac cycle has 1/3 systole and 2/3 diastole. So, when we take this into account, we find that blood has not flown 2/3 of the cardiac cycle to the brain. So, this does not mean that the patient will get an infarct, because the cardiac cycle is much smaller than the time required for an infarction, but the brain definitely gets a temporary brain circulatory arrest, and this leads to the patient going into a loss of consciousness. So, there is global cerebral ischemia for a transient period, causing the patient to have loss of consciousness. So, after this, the aneurysm bleed stops on its own. The circulatory arrest helps in the aneurysm bleed to stop, and a clotting happens. Normal clotting factors take over, and the aneurysmal bleed stops. So, this is how the pathophysiology happens around the event of an aneurysmal rupture. So, what are the causes of persistent raised ICP in an acute subarachnoid hemorrhage? We just discussed a transient raise in the ICP where the patient has an LOC or a seizure, and then he recovers, and then he lands up with us in our ED. So, what are the causes? Sometimes patients continue to have this raised ICP and go into a state of altered sensorium. So, if the volume of bleed has been significantly high, the patient is going to have continuous raised ICP, and this is going to lead to acute hydrocephalus. So, an acute hydrocephalus can set in because of a large volume subarachnoid hemorrhage or intraventricular hemorrhage. So, intraventricular hemorrhage can give rise to an acute hydrocephalus, and this causes the patient to be in low sensorium when he comes into you. So, this is one of the first things that you would suspect in a patient who is coming to you comatose with an suspected acute subarachnoid hemorrhage. So, you rush him for a CT and then plan for an external ventricular drain. Maybe when you are taking him for a CT or him or her for a CT, you can immediately plan for an external ventricular drain set to be kept ready, and you can immediately put it off in the ED, which can be life saving for the patient. Sometimes the cause can be a communicating hydrocephalus. So, basically the blood is in the subarachnoid space. So, naturally the villi which are responsible for reabsorbing the CSF get blocked by this blood and its blood products. So, this can happen over time. This may not be so acute, but again, if the bleed is so large, it can block off all the arachnoid villi which are absorbing and cause hydrocephalus, which is communicating with dilatation of the fourth ventricle. So, when this happens, again an EVD is a solution to bring the patient back to near normal sensorium. So, the more common causes are ischemia. So, suppose the patient has had a large bleed and he goes in for early ischemia, the brain starts to swell. So, sometimes you see the patients with an acute subarachnoid hemorrhage, you see that both the cerebral hemispheres are swollen, and you do not tend to appreciate the normal sulcal spaces which are normally seen. This may be one due to ischemia, and the second possibility is hyponatremia. So, these patients who present with acute swelling may require decompression, but decompression with an unsecured aneurysm is always a dangerous thing. The same thing applies to a patient who has hydrocephalus. So, once you put an EVD or decompress a patient who is having a aneurysmal subarachnoid hemorrhage, there is a chance that there is a rebleed once you acutely decompress these patients, either with an EVD or a decompression. So, we should be cautious of this. But a patient who is presenting in coma, I think I would not wait on putting an EVD in that patient. But a patient who is having mild ventriculomegaly or ventriculomegaly seen in the scan, and the patient's sensorium is holding on 14/15, or I would even say up to 9/15, you can hold on to some patients. You can repeat a CT and see if it is actually increasing in size further, the ventriculomegaly, and then decide on putting an EVD. In the meantime, you can get an angiogram and confirm where the aneurysm is, and you can put the EVD even on table. So, the next problem is patients presenting with hemiparesis. This is usually an acute event. The patient goes for infarction because of the brain swelling and change in homeostasis, and they develop a brain edema and hemiparesis. Sometimes there can be a large intracerebral hematoma. We do see these patients MCA bifurcation aneurysms, and sometimes the ACOM aneurysms which bleed into the frontal lobes. So, these large hematomas again cause mass effect, and the patient may be presenting due in a delayed fashion, causing raised intracranial pressure from which he may not recover. So, I want you to emphasize on the 3 H's which are seen in this slide. One is hydrocephalus, other is hyponatremia, and the third is hemiparesis. So, I think the old 3H concept is for the management of subarachnoid hemorrhage, which used to be hypovolemia, hypertension, etc., should be changed over to 3H's, which you have to rule out when a patient has low sensorium. You will look at hydrocephalus as a possibility, hyponatremia as a possibility, and hemiparesis. By hemiparesis, I actually mean vasospasm. So, whenever you see a patient of acute subarachnoid hemorrhage in your ICU, you should always rule out these 3 things. So, this is what I do in my rounds very commonly. I ask myself whether there is possibility of hydrocephalus for the low sensorium of the patient. Has it been addressed? Is an EVD in place? Is it working? So, this is one way to tackle point number 1. And then hyponatremia, has his sodium been checked? What is the last sodium value? Is that the cause for the worsening headache? So, this is point number 2. And then third point is he having a ongoing vasospasm? So, check for the motor power. These patients are generally in altered sensorium, but they may be good enough M6 to move the limbs. So, if you find that there was a previously moving limb and the patient has not been moving one side or both lower limbs, you would suspect vasospasm, clinical vasospasm. If there is the smallest doubt of a vasospasm, please take the patient inside an angiosuit and get angiogram done, and if required, if there is radiological vasospasm also, I think there is an indication to treat it immediately, as it will save a lot of brain. So, moving on to some more pathophysiology in this slide. So, there are 4 major things which happen once an acute subarachnoid hemorrhage happens, as shown in this slide. There is a reduced cerebral metabolic rate and the requirement of O2 that has been established in studies which have been done, especially in patients who have actually rebled with an ICP in place. So, the best studies have been done in patients who have been put an ICP monitor after a rupture, and what happens during the rupture has been best studied in patients who had another bleed when they were in admission just prior to securing the aneurysm. So, there is reduced O2, but the reduced requirement of O2 is not reflected in the oxygen extraction fraction. So, the oxygen extraction is not much. So, basically the demand for oxygen extraction or the oxygen is coming down, and then this leads to a decreased cerebral blood flow, and this causes early ischemia. So, patients who have early ischemia are the ones who go in for delayed cerebral ischemia, so DCI or vasospasm. So, this vasospasm, if there is early ischemia, these patients are the ones who have to be treated aggressively for vasospasm. Once you treat these patients aggressively for between 4 to 14 days or 3 to 14 days, they are going to do well. So, you have to treat vasospasm aggressively. So, toxic effects of the blood itself can be causogenic for several of the pathophysiology which happens after an acute subarachnoid hemorrhage. What one must understand is the treatment of the aneurysm is not the thing which is going to address any of this pathophysiology. The subarachnoid hemorrhage which has happened because of the aneurysmal rupture is the one which is causing all this pathophysiology. So, whenever a patient comes to you in altered sensorium with vasospasm, with hyponatremia, with hydrocephalus, all these are not going to be addressed by your intervention to secure the aneurysm, which may be clipping or coiling. So, what is important is to counsel the patients that subarachnoid hemorrhage treatments involves management of primary brain damage as shown in this figure. So, we will have to treat them for all these, and this determines how the patient outcome is. In other words, what I am trying to say is a ruptured aneurysm, if it is clipped or coiled, addresses or prevents only a re-rupture, but does not really prevent any of this from happening. So, even if you try to wash out, you do a clipping and you want to wash out all this blood from the sulcal spaces, maybe an early clipping also, even if you wash out, the toxic effects of the blood and this cascade which it causes because of the subarachnoid hemorrhage does not really come down. That is why even coiling patients have the same amount of vasospastic changes or vasospasm as compared to the open group. So, even removing that subarachnoid hemorrhage does not really matter during surgery. So, by meaning toxic effects of blood, they can cause excitotoxicity because of the calcium released, and this can give rise to seizures. Even though some centers do not prophylactically give anti-epileptics, it is a good protocol to give anti-epileptics for at least a week till the patient's aneurysm has been secured because of this excitotoxicity. And there are some centers which give even anti-epileptics up to 6 months and then stop. So, any patient with a history of LOC, which may be because of seizures or with a history of seizures, must be given anti-epileptics for at least a week after the subarachnoid hemorrhage settles and the craniotomy is done for clipping. The craniotomy itself warrants an anti-epileptic for 7 days at least. Additionally, there can be endothelial damage because of the aneurysmal rupture, and then dysserectoryemia, which we have seen quite a bit in the past few slides, particularly sodium hyponatremia can be caused by the toxic effects of the blood. And as we all know, toxic blood effects causes inflammation, and a lot of inflammatory response happens, and this may be even systemic, leading to SIRS. So, there can be systemic components SIRS, ARDS, all this can happen because of the subarachnoid blood. So, to speak in particular about the brain, there will be brain edema which sets in, and then primary brain injury also sets in because of this subarachnoid hemorrhage.